Hello there. This is the offline lecture for electronic ACRs, which is a component of ePC2 in your paramedic program. We're going to use a particular vendor's software in order to do our ACR assignment for ePC2. This is a company called InterDev. It's a Canadian company based out of Toronto. They've probably pretty much cornered the market in electronic ACRs in Ontario. Where you are, doing your rideouts right now, you may be using this particular software. You may be using a newer version of this software. They've actually come out with a second generation of this software that looks a little bit different. We're using the legacy version here, or you may be using a completely different vendor that may not resemble this at all. But the end result is the same for all of them. They produce an eACR that gets sent to the hospital and sent off to base hospitals and stuff like that. So as I said, we're going to use InterDev's version here. It does require a piece of software to be downloaded onto your computer. So the two computers that are set up by the paramedic labs at the very back of the building there, they have this software installed on them. So they're all good, ready to go. I will provide you with instructions on downloading and installing the software yourself. It is free software. You don't have to worry about a license or anything. And you can do that on your own laptops if you choose. However, I'm not going to provide any support for your personal laptops, just because much too labor intensive to troubleshoot, 10, 15, 20 different installations on, 20 different laptops. So the computers at the college are up and you can use them anytime you want, but you're quite welcome to try and use your own laptop anyway. The first part is we have to go to this particular website. You can see it at the top there, desktop.interdev.ca, and we get logged into their server. And once we're on their server, that's where we obtain the software that we're going to use, or the program, I should say, where we're going to use. But we need to get logged into the server first. So the username is Loyalist1 through 5. Loyalist1 I keep to myself for, accessing and marking and stuff like that. So you'll be given a password to log in here. It'll be Loyalist2, 3, 4, or 5. And of course, I'll give you the password so that you can get logged into the system yourself. But I'm going to log in here. And once I'm logged into the server, you may be presented with some folders here. So the folder we want to go into is iMedic Education right here. So I'm just going to click on that, and it'll present us with some utilities we can use. So some of these are more reporting. Some of these are for setting up the system. The one you want to go into is right here, iMedic ACR. That's the utility we're going to use to access and create our electronic ACRs. So I'm just going to go ahead and I'm going to click on this. And so what it's going to happen is from the server in Toronto, we're going to set up a link between our computer and that server in Toronto, and then we need to log into the system. So earlier I said you're going to get login and passwords to access the Citrix server, which is where we're in. In order to get into the specific program here, you'll have unique credentials to get in here. And I believe I've got them set up as like Bancroft 1, Bancroft 2, all the way down to like Bancroft 20. So there's plenty of them for you to use. There'll be one specifically given to you with specific password to use. I'm just going to log in using my credentials here. And then I'll hit submit. I actually hit my enter key, but you can always go over and hit that submit button. There's a little pop-up here saying, do you want access to this system? So permit all access is what you should be clicking on there. It's perfectly safe. It's a very, very secure database that we're going into. Permit all access is perfectly fine. And we're going to be dropped into this unfinished calls section. So if you've been in the system already and you've got ACR started but perhaps not finished yet, this is where you're going to find them. You can see that I've got one ACR that's kind of started there that I haven't finished yet. It's still available there. But for the purposes of our demonstration here, I'm going to go and click on New ACR. I want a brand new ACR to begin documenting a patient care call that I've done. So I'm going to click on New ACR, and I'll wait for that to come up. And here we are. So you may notice this looks like a paper ACR. That's kind of the very nice bit about this particular vendor software is it doesn't require a great deal of training, except for walking you through some bits and pieces here. You're going to see very quickly how this software works, and it's going to be very, very easy to use. The field that's green right now under surname, that's the active field we're working in. And this is going to be really easy to use. So I'm just going to start walking through. I'm just going to show you some of the different features and whatnot. And then I'll send you off to do your own ACRs this way. So I'm just going to start with a surname. And I might put in a surname and then a given name and a mailing address. And of course, this is completely fictional. I'm making it up as I go. And a postal code and a date of birth. Now, here's what's interesting about the date of birth and some of these other fields is they'll save you a little bit of time here. So if I want to put in a date of birth of 04/12, and if I just kind of put all the numbers together as I tab away, it'll insert those slashes for me. So it's just some little things in the software that are kind of nice. Health card number, as we all know, those are 10-digit numbers. If you accidentally put in a wrong digits, maybe you're only putting in 9 when I tab away. Unfortunately, in this case, it doesn't tell you there's anything wrong. But I'll just go back and I'll put in a 0 just to make it 10. The version code, as we've learned in the past, is two letters. Crew type. Some of these are pull-down boxes too. Now, when working through this software, you'll see that it follows all those Windows rules. So when there's pull-down boxes, I can click on it and I can select some choices here. So you can see the software has been pared down to only PCP level. What's nice about the vendors is that they can scale the software up and down to match the particular customer that they're dealing with. So that's kind of nice too. So I can select PCP. If you're writing out in an ALS service and your preceptor has an ALS partner, then we'll just put in PCP as is. But I appreciate that you want to put in all the other stuff. There's your choices: DFib, basic life support, symptom relief. I'll just put BLS for now. Service name. This is a pull down box. What's nice here, we've got Loyalist College Paramedic programs. You can just click on that. And CACs, I don't think we have all the CACs. No, of course not. There's much more than 3 CACs in the province, but you would normally pull down here and find your particular dispatch center. That might be Kingston or Ottawa or Renfrew or Toronto or London or, whatever. So we'll just select one here just for the sake of argument. What I'd like you to do here is give me the genuine call number. So a little head start towards your ACR assignment. I'm going to be having you complete ACRs for real calls you do on your rideouts. So I want real call numbers. So what we might be putting in is 1, 2, 3, 4, 5, 6, 7. It might be 7 digits, it might be 6, might be 8, depending on where you're riding out. And we'll tab away. Our call date. Well, let's put in something appropriate here. 2015-01-04. Oh, wait. It's 2016. There we go. So as I tab away, it throws in those slashes again, which is great. Our vehicle number. You can just pick something at random here. I've got some vehicle numbers in here, but it certainly is not an exhaustive list in the province. So just select something at random here. It doesn't matter if it matches your vehicle exactly. Same here with station number. There's nothing to select. Vehicle status, whatever your particular situation was. I'd like the genuine kilometers here. So I'm just going to put something in that makes sense here. But this one, if your numbers don't line up properly, it's going to give you a little bit of an error there. You can see it turned orange or red depending on the settings of your monitor. It's just an indicator that, hey, something isn't quite right with this field. So we can go back and I can fix those numbers. So obviously your kilometers should be sequential, right? And that was the problem it picked up earlier, is that the numbers were out of sequence. Your UTM code is a 7-digit, grid square number for the province. Our dispatch problem code, I can pull this down. Now here's something that's interesting. Here's all of our problem codes, but what you're not seeing is all those numbers, right? On the paper ACR, remember a year ago we were flipping over the paper ACR. We were looking for 2-digit numbers that matched the condition we were looking for, right? Let's see, chest trauma, I think that was like 54 or something like that. Maybe it was 56. The point is I don't remember, because you don't need to know them anymore. Those codes were only relevant for data entry purposes. Seeing as we're doing the data entry on the fly with the software, we don't need to worry about them. We just need to go and find what our particular call was about. So just for fun, I'm going to put musculoskeletal trauma. Dispatch priority. Here's something that's interesting. Code 1, code 2, code 3, code 4. The codes are missing, right? But if you remember, in first year, we defined what those codes were. A code 1 is a deferrable call. A code 2 is an appointment or a scheduled call. A code 3 is prompt, which means, we don't use sirens, we don't use we don't use lights, we don't use sirens, but we don't stop for coffee either. And code 4, of course, is life-threatening, lights and sirens, the whole 9 yards. So I might select that as my dispatch priority. My return priority, you've got a few more choices here, as you can see. No patient found, patient refused, patient expired. That might be your code 5. Patient in police custody. So you've got a few more choices here. And I'll hit prompt. Number of patients, 1 of 1. That, of course, could be, 2 patients, 1 of 2, and 2 of 2. If you leave somebody behind, if it's a no patient carried, this would be a 0, and this would also be a 0. Here's all your special codes. Now, if you remember your paper ACR, on the back of the paper ACR, if you flipped it over, there was like a column and a half of special codes. There was tons of them in there. And you'll notice, even though there's tons of information that can go into special codes, there's no drop-down box because there's just so many. So I'll give you a little hint. If you hit F5, it brings up another box. Here's all your special codes. And you can go through and you can select all these. So I might, select a couple of these just for fun. And then I'll hit return when I'm done. And you'll see those special codes get added in here. So we're off to the races. As I'm moving through this software, I'm just using my tab key. So I started all the way up here at surname, and I'm just tabbing through the different fields. So if you remember that part, if you just use your tab key to move between the different fields, you'll pretty much have an opportunity to put something on in every important box. If you just go through here and you click here, and then maybe you click here, then you come back up here, and then you come over here, chances are you're going to miss something. But if I just tab through, then I'll be able to hit every field that I need to put something in. Warning systems, siren and lights, to destination, maybe I didn't use anything. Pickup sending location, you can put in an address, you can put in cross streets, 401 westbound, that sort of thing. This right here, same as address. You can click on that and it'll fill it in with the mailing address here. So that's a shortcut if you happen to pick somebody up at their home, which is the same as their mailing address. But of course, we don't always pick up people at home, right? This could be, Yorkdale Mall, Toronto kind of thing, instead of the mailing address. Pickup location code. Here's all those location codes. Factory industrial 3 floors up, so something like that. If you're doing a transfer, sending hospital, obviously we don't have a tremendous number of hospitals in here because this is only an education software. but there's a few of them in here. For your genuine ACRs, we would just probably pick Bancroft just because it's simplest. Chief complaint. This is a free text field. You can type anything at all you want in here. But of course it should make sense, right? So maybe for this patient, we were dispatched under musculoskeletal trauma. So maybe I'll put femur fracture. And my primary problem might be musculoskeletal again. So let's go down and find that. There it is. There's 2 fields for secondary problems. So if you have more stuff going on, you know, maybe he's having some, oh, there's a good idea. How about some emotional distress secondary to his femur fracture? Why not? Time of occurrence. This is a genuine time. This is understood to be an estimated time, but they want a genuine time in here. So I'm going to put perhaps 10:30. When I tab away, you'll see it actually tossed in the date for me too. So if you have, you know, somebody complaining of a chronic problem that's, you know, 2 or 3 days old, typically what I'll do is I'll probably put, you know, 8 o'clock or noon or something like that here. And then when I tab away and it inserts the date, I'll go back and I'll just modify the date right here. Right? So I just might change that to 2. And that's 2 days earlier kind of thing. So our incident history, this is a free text field. You can type whatever you want in here. So this, of course, is your story. This is your, you know, patient fell downstairs, you know, landing on concrete floor. And apparently I don't know how to spell concrete. So luckily, it underlined it for me. So I can go back here, I can right click on it. Oh, and it gives me the correct spelling for concrete. Fantastic. Maybe I'll put no loss of consciousness. Maybe right leg found, you know, shortened and rotated outward. And something like that. And you can continue your story with there. You know, you're obviously going to put a much more detailed story than I am for my particular demonstration here. Tabbing over to our trauma matrix. Again, the location of the trauma, so we can select that. I'll come down here and I'll find femur or leg, knee, lower leg. I guess thigh is what we're after for femur. Tab to type. Here's all the different types. So I think possible fracture is a good choice here. And mechanism. Maybe I'll put fall from height because we kind of went downstairs. Kind of makes sense. And if we had more traumatic injuries to document, we could just insert them here. So I'll just tab through these. Let me just scroll down a little bit here. And we'll look at our entire clinical information. So we started with the incident history as our clinical information. Here is all of our tick boxes from that paper ACR. So we can tick stuff here that makes sense for our patient. And then we're followed up with a free text field that we can, you know, type in stuff. So for cardiac, we could put, you know, previous MI in 2008. Maybe he also has hypertension, and I also selected seizure, so maybe I could put epilepsy, epilepsy. There we go. And I can tab away when I'm done. For medications, maybe he takes nitro, maybe he takes Lasix, maybe he takes ASA. I can use those tick boxes, and then I can be more specific, just like in the paper ACR. You put nitro, 0.4 milligrams. Whoops, PRN for as needed. I can put Lasix, 200 milligrams, you know, BID, ASA, 81 milligrams, QD. QD is daily, BID is twice a day, PRN is as needed. If you don't know all those short forms yet, you should have learned them during the pharmacology course or maybe the medical terminology course. If you've forgotten them, you might want to remind yourself of them again. If you have any allergies, you can click them. You can type in if you want. Totally your choice. Treatment prior to arrival, you can use the tick boxes. You can document, different things that went on prior to your arrival. As you can see, this is pretty easy stuff to use. It's just click and type. So, there isn't a tremendous amount of stuff to show you here. I'm just working through my eACR. Cardiac arrest information, same as the paper eACR, so some tick boxes. Some of these, they want a genuine number of minutes, so maybe 12 minutes. Estimated time of arrest, they want a genuine time. And when I tab away, it puts in the date for me. So if you're working over midnight, if the arrest was before midnight, but you're doing your eACR after midnight, you might just have to keep an eye on that date there and make sure that it's the right one. Make sure you don't have to back this up a day. Time of shock delivered to patient by first provider, we could go 12:36. And again, it puts in the date for you. The age gets automatically calculated from the date of birth you entered, which is brilliant. I love that. That's worth the price of admission. I don't have to sit and calculate the date like I did on the paper eACR. For gender, male or female. For weight, here's another one. Again, worth the price of admission, the weight. I learned weights in pounds. I'm a little bit old school, and I learned weight in pounds, so I always have to do that mental math and 2.2 pounds in a kilogram. How many kilograms are you? The software will do it for me. So I have a look. If I look at somebody and I say they look to be about 180 pounds, I'll put 180 and I'll put an L. So that's a lowercase l, but that's an L. When I tab away, it does the calculation for me. Brilliant. Love the software already. It's done 2 pieces of math I don't have to do. It's calculated the weight for me, and it calculated the age for me. Brilliant. Your CTAS level, your skin condition, normal, normal, normal. I'll come over here to general appearance, and this is where you get to tell more of your story. Patient found on floor at bottom of steps. Alert ×3, in obvious pain, that sort of thing. Again, you will be much more descriptive in your documentation here. I'm obviously just trying to lay this out quickly. Now, these free text fields here, and you'll see there's one here, and one here, and one here, and one here, and one here. All of these have got another nice little feature about them. They call it the sentence builder, which personally I don't use it very much, but sometimes you've got that descriptive word you're trying to think of and it's just on the tip of your tongue, but you can't quite come up with it. But it might be in here. So what I'm going to do is I'm going to hit F5 like I did earlier. And now I'm presented with a lot of descriptive terms that I might be looking for. So maybe there's something in here that was, like I say, just on the tip of your tongue, but you couldn't quite come up with it. And then you realize, oh, it was anxious. That's the word I was looking for. So you can click on that and hit return. Head, neck, trachea, JVD not elevated. If I come back here again, I can hit that F5. And now here's some descriptive words again. But the descriptive words are changing each time. They're dialing in to the section you're in. So we're in the head, neck section here. So it's going to provide us with some descriptive words that apply to that section. Scalp, forehead, ear, eye. And as I click on these, you'll notice they're being filled in down here. There's some more. And even more. So tons of stuff that you could document in here. Saliva. When I hit return, it all gets entered in here. So they call it a sentence builder, but it's not really a sentence. It's just a list of words. So you still have to go in and make this kind of make sense, right? But like I say, maybe if you're just looking for that specific descriptive word and it's on the tip of your tongue and you can't quite come up with it, you can find it here. It's chest, clear breath sounds, continuing the example to the F5 again, and you'll see the descriptive words are changing each time. They're detailed to the particular field you do. And there, and there, and there. And just one more time, show you the F5. And again, you'll see the descriptive words are changing here. It's brilliant. Maybe the hand, mobility, that sort of thing. You can pick out those words you want to use, and you can insert some, your words for the rest of your sentence to make it all make sense. Has mobility, issues due to previous amputation. Who knows? I'm making it up as I go. So that pretty much is page 1. Very, very straightforward. So I started all the way up at the very, very top here at surname. And like I said, just hitting tab as I work my way through, I hit all the fields that need something entered. As I said before, some of the fields are pull down boxes. You can go find the particular one you're looking for. Some of them are free text fields that you can just type whatever you want into. And some of them are tick boxes where you just tick them or untick them. So let's go down to the bottom here because that's the end of page 1. Starting at the very top left-hand corner of page 1, tabbing through all the way down to the bottom. By the time I get to the bottom here and I've finished typing in this field, I'll have hit every field on page 1 that needs to have something put in it. So let's go to page 2, shall we? Here's page 2. This is our chart. We're going to start building our chart. Our procedures, everything we need to create our ACR. So on the left-hand side here, we've got all these buttons. These buttons are broken up, everything that was on the back side of that ACR. So when you flipped over that paper ACR and you had all of those procedure codes on the right-hand side of that paper ACR, they're all here. We've just grouped them into buttons to make them easier to find. So I'm certainly not here to teach you how to do an ACR right now. I'm just teaching how to use the software. So you're going to build your chart the way you have been all along. You're probably going to start with a BLS assessment. You're going to have vitals. You're going to have, transport. You're going to have, medication. You're going to have defibrillation. You're going to have CPR. You're going to have, dressings and bandages and stair chairs and all that stuff depending on the particular call. So I'm just going to walk through these one at a time and show you what's in them. So the vitals box is the first one I'll show you. So I'll click on that. And it brings me up a vitals screen. So this is a pop-up. I'm going to put in my time that I did a set of vitals. And I'm just going to start tabbing through. Heart rate, 123. Regular, full. Maybe my respirations were 18, regular and full. Systolic was 126 over 88. It kind of skipped over the temperature there. You can always go back and put in a temperature. But the skipping over, that's all configurable in the software. The vendor would, talk to the customer and say, what order do you want me to highlight stuff and stuff like that. If you're documenting an ECG, if you had a lead 2 on, then you might do a normal sinus or something. But let's pretend I haven't done that yet. 98%. End title we haven't done yet. Here's our GCS. Watch this. You're going to love this. Spontaneous, oriented, obeys commands, GCS 15. Here's the third time that the software is calculating something for you, so it's less math. So if I change these up, and when I go by, GCS a 9. It's brilliant. It does the work for you. I'll just go put these back to 15 the way I like it. Pupils, maybe we're 3 and reactive. 3 and reactive. And then here's where we give credit to who did the work. We skipped over patient status and pain scale, but you can fill those in if they make sense to you or if they're applicable to a particular moment in time. Crew 1 and Crew 2, depending on who did the work. So I'm going to hit Crew 2. I'm going to hit Return. and it creates that vitals line for you. Now, if you need to review anything, you can see it's actually doing it right now. Usually, if I go up here and just kind of pause over there, I can see what's in there. Now, I have my screen resolution dialed way down just for the purposes of our demonstration right now. But if you had this open on your laptop with a much higher screen resolution, you'll see that whole line with all of your vitals in it. So you can do vitals. You can do as many vitals as you want. What's nice about this is usually when I do a call, my very first time I do a set of vitals, I'll fill in the screen completely. For subsequent vitals, maybe I did another set of vitals 5 minutes later at 12:50. I just used the little up and down arrows here to change that time. You could have typed that in as well. Usually on second set of vitals, I'll only change what has actually changed. And maybe their SATs went up to 99. And crew 2 and done. So you'll see my very first set of vitals, I usually do them completely. Subsequent set of vitals, I only enter what changes, right? So, respiratory rate didn't change, GCS didn't change, so I've only typed in what's changed. So that's just the way I personally do my ACRs. Just a suggestion to you. So vital signs, that's pretty straightforward. Under IV, we should only have a couple of things available. It does actually have everything available. But probably for you, the starting out PCP, maybe only doing IV monitoring. But if you have an ACP partner, maybe they put in a saline log, or maybe they start an IV with normal saline. So you can fill that in. Where did they start that ACR? Maybe in the left hand, TKVO, maybe they used a 20 gauge, and maybe crew 1 did it that time. And I'll hit return. I'm ignoring this chart results here for the moment. I'll show you what that is in a minute. For the moment, I'm just going to hit return, and it created my line. Medications. Here's a medications box. So again, I can just change my time a little bit. Maybe it was 2 minutes after a set of vitals. Maybe I gave ASA. The dosage is 81 milligrams. MG. How do we give ASA? We give it oral. Maybe crew 2 did it this time. And now I'm going to point out chart results because I've ignored it up until this point. Return would simply, as I said, just create that line. But let me show you a different way. Maybe this time I'm going to put nitro, 0.4 milligrams. Nitro is given sublingual, so we'll go down here and find sublingual. Pick out the crew member that did it. This time I'm going to hit chart results. And chart results is a shortcut to a vital sign screen. Because often when we give a medication or some other treatment, we need to document the results of that treatment. And usually we document the results as a set of vitals. So after my nitro, maybe my patient was complaining of some chest pain. Maybe their pain got slightly better. Maybe the 8/10 chest pain, reduced. Apparently I don't know how to spell reduced to 6/10. And I'll just right click, reduce, there it is, to 6/10. That's my results. Crew 2, hit return. And so what it does is it marries these two lines together. 615 nitro spray, and you'll see here it says, and wait for it to highlight, see associated vitals. The line immediately below is the associated vitals. And there's our pain slightly better, 8/10 chest pain reduced to 6/10. So that's what the chart results is all about. It jumps you to a vital sign screen, and then you get to document the results, what happened to your patient as a result of giving that medication. And you'll see, I only use that one section of the vital sign screen. I didn't fill it out completely. You certainly can if that's how you choose you want to do your ACR. There's nothing wrong with that. You might get some of your information lost in the vast amount of vital signs. So anyway, let's carry on with the rest of these buttons. Airway. So this is going to be airway management stuff. So just a couple choices there. Oral, nasal airway. King LT. There's no LMA here. Just because most of the province is using King LTs. You don't need to worry about this type because that applies to endotracheal tubes. But you do need to know the size you used of King LT. Size 4. If you're using oral or nasals, you would put in the size there. You know, your nasal might be a 21 or a 23. Your oral might be an 8 or a 10. Ease of intubation doesn't really apply here. You can put easy or difficult, depending on how easy or difficult that King LT was to put in. Reason for using that King LT? Well, probably airway protection is a good choice. And this section here is what did you do to confirm placement? So absolutely some of these apply. We don't visualize the chords when using the King LT, but we do auscultate the epigastrum. We do auscultate the chest. We do observe for chest rise. And I'm hoping you are in fact using end tidal CO2. So you can use all this stuff. Even though it says intubation, here, it applies to all of your devices here. At least some of them apply to all your devices here. There's your return. Here's your chart results if you want to jump to a vital signs screen. And here's your crew 1 and crew 2. Now, something else I've kind of ignored to this point is it only says crew 1 and crew 2. And you as the paramedic student are actually number 3 on that crew. So far, you haven't been able to document yourself as doing anything. If I leave these blank, if I don't select one of these and just hit return, there we are. It'll bring up who did it. So here's all the rest of your choices. So there's you, number 3, that you might select. You might have another 4th crew member. You might have a bystander, an ALS crew, firefighter, first response, a doctor, police. You can give all these other people credit for doing work for you. And hit return when you're done. So here's the difference we've seen. Up until here, I've just been selecting crew 1 and crew 2. Here's the one, crew 3, I had to open up that extra window. All right. ECG, so this is all your electrical stuff. Cardiac monitor, this is just your garden variety, just doing the lead 2, for anybody. Defibrillation, this is actually delivering a shock, so maybe 120 joules. Whoops. 120 joules, not 1200, 120. This one here is an analyze that resulted in a no shock advised. Time of first defibrillator at patient's side. That's kind of an important thing that we started documenting a couple of years ago. Just capturing the time that defib arrived at that patient. It doesn't necessarily mean you, the paramedic, with your defib. It could be fire department defib. Could be a public access defib, that sort of thing. The only thing that's missing here from this procedure is 12 lead, which is funny because everybody does 12 leads. Normally there's another line here that says 12 leads. But anyway, I might put cardiac monitor. Maybe crew 1 did it. I'm putting on my cardiac monitor for a reason. I want to read that ECG. So I'm going to take advantage of my chart results. And after putting on the cardiac monitor, I discovered normal sinus rhythm, crew 1, and hit return. So here again, we've got 301 cardiac monitor, C associated vitals. The associated vitals are ECG normal sinus rhythm. The other thing I've noticed lately is I haven't been changing my times. So you got to get in the habit of changing those times as you go. Otherwise, you have to keep going and reopening these and changing all your times, which can be a bit daunting, particularly when you've got a nice big chart that you've built. So if you get in the habit of modifying your times every time, on every window, it'll just help you out in the long run. Ventilation, this is all your oxygen stuff. High concentration mask, nasal cannula, Flomax. Some services like to document Flomax differently from a normal high concentration mask. Not really sure why. They're the same animal, it's just kind of a different manufacturer. And BBM. So here's what's interesting. If you're watching over on this side, for a simple face mask or a nasal cannula, it's just a flow per minute, because that's the only thing. When I selected BBM, now it wants 2 things. It wants the flow rate, so maybe I'm using 15 liters per minute, It also wants how many breaths per minute were you providing to that patient. So, depending on what you selected here, it brought you some, more or less detail on this side. Crew 2, hit return, and we're all set. BLS, this is pretty much everything else, right? This is not medications. This is not electrical, right? This is everything else. This is all your BLS stuff. So here's your BLS assessment. ABC okay, alert, that sort of thing. I haven't been modifying my times, but that's probably the very first thing I do. I'm just going to pull this over just a little bit. 12:45. I'm going to back this up to 12:44. 44, because I always do a BLS assessment first, right? You hit return. Now my times are out of order. That's kind of frustrating, but this chart here is kind of like an Excel spreadsheet too. I can just click on the heading here and I can resort anytime I want. And as you saw, the BLS assessment jump to the top. So if you looked at this and you went, oh, geez, I gave my ASA, much earlier, I can double click this, reopen it. I can change the time here, hit return. It's still down here, but I can resort and it jumps up here. So you can always go in, you can change your times and you can resort that chart anytime you want. That's another great thing about electronic ACRs versus paper, right? Once you wrote something on paper, there it was, you were stuck with it. Labs, this is for lab values for critical care medics. I'll open it up and show you anyway. But obviously, we are not as PCPs doing any lab gases. Myself as an ACP, I don't do lab gases. But if you're in the middle of a transfer between hospitals and you have an opportunity to look at lab work, take the opportunity. It's interesting to read. X-ray, same thing, doesn't apply to your skill level as a PCP. Patching, this is important. If you patch to your base hospital physician for a patch point in your protocols, you can document it here. So what time did we do that patch? Maybe at 12:57 I did that patch. Here's what I patched for. So you can see that there's lots and lots of stuff in here. But probably one of the things most often you're going to patch for is a termination of resuscitation. The order issued, you can type in here. TOR authorized at 12:59. And when I click add order, it goes down here. So the ACP in the crowd, who maybe is collecting 2 or 3 different orders, maybe are gonna, line up their orders here. So they're typing in each order at a time because maybe they've gotten 3 or 4 orders from the doctor. So you can see they're just lining up here. Obviously this stuff doesn't make sense. And I'll hit crew 1 and hit return. And it says base hospital patch C remarks orders. The remarks orders are missing, right? They're not. They're actually down here. If you read your ACR completion manual, it tells you that patch orders must be documented down here in this remarks section. So it actually follows the ACR completion rules quite nicely. Other, I'll click on that. And this is just pretty much everything else that doesn't fit anywhere else, right? This is kind of, odds and ends, extra stuff that services have asked for, triage reports, offload times, those are quite often, want to be recorded by the services. CTAS on contact is something that you may be doing where you're riding out now. So there's CTAS on contact, sudden cardiac arrest, CTAS on contact 1. Patient valuables, receiving facility bypass. This is all different things that services have may asked for. They don't really apply to the ACR itself. They don't follow the ACR completion rules, but they're just things that are great to document in your ACR. And you can see very quickly, and even perhaps in your write-outs, you're seeing very quickly how the documentation is evolving beyond the paper ACR that we were really stuck in the box with a number of years ago. we've really been able to expand and document a lot more than we used to. And I'll just X that. And then finally, this quick button here, I'll show it to you quickly. This is just a feature that they added a number of years ago, where it rates all of the different procedures by frequency that they show up in ACRs. So, you know, BLS assessments should be very high on the list because every single patient should get a BLS assessment, right? So you expect it to be high, and here's the frequency that it shows up in ACRs. And if I just scroll down here a little bit, you can see all this stuff is here. So the intent from the vendor was to double click and it gets added to your chart, and double click and it gets added to your chart. And I'll just go down here and I'll say double click added to your chart. So it's meant to allow you to build an ACR very quickly. And when I hit return, you'll see it added in those lines very quickly. There was no time attached to those, so they kind of got populated at the top of the chart. But it was meant to build a chart very quickly. The trouble is you have to reopen all these. And now I need to put in a time and maybe put in some notes or whatever. And maybe I hadn't been pointing it all along, but all of these different buttons had a free text note field. You could type in whatever you want and hit return and then resort. So, like I said, some of the stuff is really, really valuable. This quick button here, I don't know anybody that uses it. It's just a little bit awkward to use. You can maybe build a chart quickly, but then you have to reopen each one and fill in information anyway. So as far as I know, nobody really uses it. I'll just come down here and we'll just finish our ACR very quickly. Fluid balance. If you have a patient that has started an IV, very quickly we can just put in here normal saline, pre-transport maybe 100 mils, en route 200 mils, and you can see it does the math for me, which is brilliant. Patient outcome and emerge, it's just ticks box. Final primary problem and final status. And base hospital, I don't think there's anything in here. No, there isn't. So you can just leave that one empty for your practice ACRs. Receiving facility, again, choose Bancroft. Here is our receiving facility. That's perfect. As far as function, I would like you to put yourself down as attendant, and you'll be able to find yourself in here. So you see I've got these Bancroft numbers here, and right here you can see I've got some student names from last year. I'll be going in and putting everybody's names in properly here, but I'll just show you as an example. Bancroft 2 was Victoria Allen last year. So that's the attendant. You can add a partner, a driver, and you can just select anybody at random here. I'm not going to go in and populate the database with all of your preceptors and all of your preceptors' partners. That would just be, an exhaustive amount of work that is not really useful for you to do for ACRs. But so put yourself as attendant, and put in anybody else you want as a driver. Travel conditions, as before, good road conditions. Call events. There's a date and a time. On your paper ACR, there's only time, but here you get date and time. So usually what we do is we go down here. If you know the time that the 911 call was made, you can put her in there, but usually people start at crew notified because that's when the ACR started for you. Crew notified at 11:55, and as I tab over, it inserted the date for me. 12 o'clock we went mobile. I don't know why it took full 5 minutes to go into service. Arrived scene at 12:02. Arrived patient at 12:04. Depart scene at 12:55. Arrived destination at 1300. If you roll over midnight, the date will actually change. So let's actually try that. Let's see if I get an error. or if it'll change the date for me. Well, it just gave me an error because going from 1300 to after midnight did not make sense to the software. As well, it shouldn't. So we're back to here. And once you're finished with your ACR, you can click Done. You can click Done. Thank you. And now it's going to go through this compliance checker. Now, they don't have any compliance rules turned on in the education database here. If you're working for a service, they will actually run this compliance checker. It'll compare your ACR against, anywhere from, 60 or 80 to up to 500 different rules that the ACR should meet. And it'll do things like making sure if you've documented nitro, it'll make sure that none of your blood pressures are below 100. And if there are, it'll alert you and say there's something not right here. If you forget something, it'll come up and say you forgot to document, starting mileage. You forgot to document a primary problem. For education purposes, they don't have it turned on. So I'll just hit exit here. And we just kind of get one last thing here. Confirm receiving facility. I can go yes and yes. And once I click yes, your ACR will be complete and submitted to me. What I'm going to do here is I'm going to hit cancel because I want to show you just a couple more things. One thing we didn't do is actually sign our ACR. What I'm going to do is I'm going to click here. And we can actually sign here. Now the intent, of course, is that this is done on a tablet with a pen that you can actually capture handwriting. I'm doing this on my laptop, and I don't have a pen, but I can use my mouse and I can go ahead and sign my ACR, and I can get my partner to sign, so that sort of thing. And hit save when I'm done. That's great. If I've done a refusal of service, that's actually here. And I'll click that. If you've done somebody who has refused transport and you're signing them off, this is where you would use this section here. So you might go in here and you might put, John Doe 123 Main Street, Belleville. And obviously this is meant to be written in with a pen, and I'm not going to, with my mouse, very carefully write stuff in. But you can fill this out exactly the same as you do in the back of a paper ACR. And collect and say, sir, sign here with the pen on your tablet. That's the intent, right? And the patient would sign their name. And I can just scroll down here a little bit. And at the bottom here, this is your signature as the attendant. Here's your partner's signature as the witness. And as I was clicking on these, you'll notice they all get time stamped. And that's kind of important. That's a requirement for electronic ACRs, is things like signatures get time stamped. And I can save that. If I want to go back to page 1, I can jump back here, page 1. If I need to go and check something here or modify something, I can go back to page 2 by clicking here. This one here is to go back to my unfinished calls. So if I click on that, it's going to ask me if I want to close the current call. Close doesn't mean finished and submitted. It just means I'm closing this call for the moment. And it's going to go into my unfinished. And there it is. It's ready to go. Here's the old call that was in there previous. Here's the brand new one I started. So I can double click on that, or I can come down here and click load. And click load. It jumped around a little bit on me. There we go. And we've got our ACR back. So once you're finished, once you have completed and you're completely happy with your ACR, which I'm hoping you will be, we'll hit done, as I said before. There is no compliance rules, so we'll just exit, confirm the facility, hit yes, and it is gone. If I go back here to unfinished calls, you'll see it's no longer there. It's been submitted, it's gone. It'll be waiting for me, the instructor, to go back and mark your ACR. So that's just a quick introduction to the electronic ACRs. I will be sending you details on your ACR assignment and how to access the system with your credentials and everything. And as I said, there will be instructions for downloading the software onto your personal computer if you choose. Otherwise, you're quite welcome to use the two computers at the back of the building by the paramedic labs. They're set up and ready to go for ACRs anytime we want. I'm going to exit the software now, and I'm going to exit this, and this will be the end of our tutorial for tonight.